So without further ado, I'd like to introduce our speakers for this breakout session. So first we have Peter Hilen. He's a licensed marriage and family therapist. He's worked in the field for 15 years. From 2007 to 2012, Peter managed a variety of program types, including inpatient substance abuse, outpatient substance abuse, inpatient geriatric psychiatric treatment, adult crisis residential programs. Currently, Peter is the Telecare residential standardized group and has assisted in many startups over several newly established crisis residential programs in Contra Costa County, Orange County, Riverside County, and San Bernardino County. Peter has participated in several community and privately held corporate boards such as the Salvation Army in Los Angeles and the Orange County Substance Abuse Network. He is the administrator for the Telecare Treehouse Central location in Orange County, and Peter lives with his wife and 3 kids in Orange County and is an avid hockey fan. Co-presenting with Peter is Travis Atkinson, consultant for TBD Solutions. Travis is a licensed professional counselor, has worked in the behavioral health services for the past 15 years as a clinician, trainer, supervisor, advocator. He is presented at SAMHSA panels around crisis systems and crisis bed registries, researched the best practices in emergency behavioral health care, and spoke at national behavioral health conferences on functional crisis systems and behavioral health care workforce challenges. Since 2015, he has worked at TBD Solutions, and he is instrumental in the authoring of the Crisis Best Practice Handbook in 2018. If you haven't gotten a copy of that, I suggest you grab a copy. You can do that by going to the website and requesting it. Great handbook full of really important information. Travis has his bachelor's degree from University of Michigan and his master's degree from National Louis University. He's the co-chair of Crisis Service Committee for the American Association of Suicidology. All right, I think we're ready to rock and roll. As I said, if you have any questions, please put them in the chat box, and we will get to them at the end.
Today, our session, how can we be the most helpful? Practical strategies for critical engagement. So I would like to start by talking about the question of whether faster is better. And if faster is better, who is it better for? So in the movie The Founder, Ray Kroc, who's played by Michael Keaton, goes to McDonald's for the first time when he's on a sales call for a different job that he had. And he walks up to McDonald's and he makes his order. And within about 10 seconds of paying for his order, his food is ready. And this is the face that he is making. And he's kind of staring in just befuddlement about how quickly his food was ready. He assumes that maybe it was somebody else's food. He's not sure. He's not sure what happened. But he is trying to figure out why his food was delivered so quickly. And if you're familiar with just the concept of fast food and using supply chains to get a food made as quickly as possible and having a very simple menu, it made sense to the workers. Certainly didn't make sense to Ray Kroc in this movie. So fast forward to just a couple of years ago, and I had walked into a McDonald's myself on the way back from a road trip, and I see this. I see this screen that patrons are being directed to place their orders on. So instead of going to the station where you would normally place your orders, you go to these touch screens and you place your order and you can pay by credit card. And it was an attempt to create some efficiencies in the process. But as a people person, I might not have necessarily appreciated talking to a screen and missing out on that human interaction. And there's many other challenges that can come along with thinking that something that's faster or more efficient is necessarily going to be better. Now, this was good for the staff, perhaps because they didn't have to hire as many people. Maybe it was less costly, and they were trying to make it better for the customers as well. But we have to ask this question in mental health also, that is it better to receive your crisis services more quickly? And if that is the narrative that's being promoted, then who is that better for? And so that's a little bit about what we're going to talk about today. So my name is Travis Atkinson. I work for TBD Solutions. I'm also a proud board member for the Crisis Residential Association. I've been working in behavioral health for 15 years, including about 5 years in crisis residential services, as well as psychiatric hospitals. And I'd like to now introduce my friend Pete.
Thanks, Travis. I'm Pete Hilen. I've been working, just like Travis, been working in the field of behavioral health for the past 15 years, and I work for the Telecare Corporation out of Alameda, California. I've managed and operated a few crisis residential programs, and I also am a proud member of the board member of the Crisis Residential Association. So happy to be here, and there we go.
So before we dive into talking about the most helpful level or amount of care, we want to preface this by talking a little bit about what the crisis system has done from an evolutionary perspective dating back to before the 1970s. So think about that voicemail that is on your doctor or your primary care office's voicemail that says, if this is an emergency, and then the rest says, hang up or dial 911 or go to your nearest emergency room. Now, emergency rooms and 911, those are great innovations that have come out of emergency healthcare. But we have sent people in a behavioral health crisis through those same pathways. Dial 911. Sometimes law enforcement gets involved. Or you dial 911 and then perhaps an ambulance might show up at your house. From those places, you're transported to the emergency department, or if you're in a crisis, you may present directly to the emergency department. There, if you don't have many choices and it's before the 1970s, you're probably going to end up at a psychiatric hospital. So there's been a lot of innovations since the 70s that have helped people in behavioral health crisis to get better access to better care. So an ideal continuum might look more like this, where you're replacing your 911 operator with a crisis call center or suicide prevention hotline. You're replacing your police intervention with a mobile crisis team, a team of clinicians and perhaps peer supports who are going out and trying to diffuse or de-escalate a crisis in the community. And then instead of going to the emergency department, you start to see these other options open up. Certainly crisis residential services is one of them. You also see 23-hour psychiatric emergency services. And depending on where you live, these could be called crisis stabilization units or CPEPs if you're in New York State, for example. And then lastly, peer respite facilities. Now, the great thing about peer respite is it helps to expand the idea of what crisis is into emotional distress. And it really relies on the agency and autonomy of the individual who is self-identifying their crisis and their ability to function in a peer respite home, a facility that is entirely staffed by people with lived experience. So today we're going to be talking about crisis residential. Obviously, this is the conference that we're at here today, and about what is ideal in crisis residential services. How can we be the most helpful in these services, and how do we know what is helpful, whether it's the length of time that a person spends in the facility or the type of treatment that they receive? So here's a timeline of crisis treatment, and we've broken up crisis treatment into 3 categories. Now, nationally, we have learned through surveys that crisis residential services can range in length from 3 days all the way up to 30 days, depending on where you live or what your state's jurisdictions are. And we've kind of broken up what you can expect in these different phases based on how long the stay is or how far into the stay that you're in. So we have stabilization, respite and recovery, and skill building and social determinants of health stability. And so each of these we've coded into 3 different sections. So stabilization happens in the first 72 hours, respite and recovery happens in the first 3 to 10 days, and then skill building and social determinants of health stability happens in 10 to 30 days. And so Pete's going to talk us through these first few stages of what crisis treatment is like in that stabilization period.
Great. So if we start with the first stage, which is stabilization, and we've identified this, like Travis said, as the first 24 to 72 hours that a person is enrolled in a crisis residential program. This is a really time-critical moment for an individual who is entering one of these programs. It's fair to say that most people coming into a crisis residential program haven't had their best day, and so they're in a really, really sensitive and probably the most acute that they'll be upon entering the facility. But this is a great opportunity for us to make that connection right away, to start to provide as much support possible. Usually what's going on, very generalized, standardized processes that crisis residentials follows. There are going to be the assessments, the evaluations, and meeting with physicians and clinicians. It may be an orientation and those types of things, but also this is also an opportunity to really address the initial crisis. So maybe we're starting medication or restarting medication that the individual is going through. Maybe just that simple removal from that crisis, that stressful environment into a new environment, which maybe is more supportive, or maybe just a bed to sleep in, off the streets or out of a shelter, is extremely helpful for that person. And what we're talking about here is really short-term goals. So really, we're just talking about, we're looking at that, just getting that person comfortable, reestablishing some routines. We're going to start to talk about developing safety plans and RAT plans and those types of things, and we're going to complete some basic assessments.
And Pete, one of the reasons that we decided to break these up is that sometimes expectations can be the same across different types of crisis residential programs, regardless of the length of stay.
Yeah.
Now, the programs that you've supervised, they have about a 2-week length of stay or so?
Generally, yeah. So, Telecare operates several crisis residential programs, and generally they're following the 2-week. We have a few 30-day. It's really based on county, but for the most part, you could say the average length of stay, at least in the ones I've operated, the average length of stay has been relatively short, about 2 weeks.
Okay. Now, and we know in other parts of the country, some even CRA members report a length of stay of 3 to 5 days. And so it can be really ambitious if your funder or your referral source expects you to get through a lot of these helpful interventions in a very short period of time. And we'll talk about that in a little bit as to why that becomes so difficult. So Pete, do you want to talk about respite and recovery, this 3 to 10 day phase now as people move along a little further in their stay?
Yeah, sure. So a person moving out of the stabilization period and into the respite and recovery, this person, I think, you're starting to focus and hone in on really, what are the areas that they feel really need to be addressed while they're there. They're starting to attend groups. They're really beginning to develop some resiliency, which is really important when you're talking about stabilizing from a mental health crisis. The development of resiliency will impact how long they will be able to maintain recovery, either while enrolled in the program and even after they disenroll from the program. Maybe it's a re-engagement or an engagement in support systems like family or community-based programs. Maybe it's a re-engagement with a former provider that they for whatever reason haven't been engaging in. And so in this 3 to 10 day period, we're really talking a lot about setting the stage for what will help them address and maintain their behavioral health recovery for the long term.
So then this 10 to 30 day stay is going to focus on skill building and social determinants of health. So if you've been in the program for over a week, you know how the schedule works, you know what expectations are. Maybe the people that you serve contribute to chores around the house or daily activities. Maybe going to the local farm stand and picking up some fruits and vegetables or something like that for the dinner. But the goal here is to develop these skills and stabilize the environment. So we want to verify that the housing is current, or this is a time to secure new housing. You want to monitor those slower acting medications. Antidepressants can often take weeks to start. Do you want that to happen in a supervised environment that can also have some social rehabilitation components? Or do you want that to happen back at the person's home when the medications might not be working, and then they need to go through the crisis system process all over again?
Right, and those issues can be addressed at that time, so they can address them while they're in there. They could and maybe adjust. So there's even an adjustment period that could go through when it comes to medication and slow acting medications. So
yeah, and so when you're away from your environment for this long, some of those traumatic or stressful triggers can subside. But then the clinical team or the treatment team in the crisis program is going to start to help you to find this new normal. This new way of living that maybe you keep some of the toxic people out of your life. You start to develop some healthy patterns, whether it's sleeping or eating. And then transportation support is very important for whatever the next step is. You don't want to put someone, outside of your facility where they're moving 30 minutes away, and you kind of are just hoping that they're going to get there. You might lose all of that progress that you just made, or that person just made in those first several weeks. So, Peter, I wonder why don't you talk about admission? I'll talk about the middle here, and then you can talk about discharge. And again, trying to think of treatment as this arc or this progression, and what are some of the attitudes or beliefs or feelings we might see in each of these stages as a person comes into a crisis residential home, maybe for the first time.
Yeah, so like I said earlier, I think the initial admission period for an individual when they enter a crisis residential program is it's a unique time in their recovery. Often they're very skeptical, hesitant. They might be extremely symptomatic, which might exacerbate some of these feelings. Although they might have the opposite. They could even be a huge sense of relief. They could all of a sudden have this overwhelming feeling of, oh my God, I'm finally going to start to work on me, and I'm out of that initial critical environment that I was in, and so what a relief. And so they're able to actually let down their guard a little bit, which can be scary for some people, can be a very vulnerable situation. So but they really, I think it varies from person to person. Maybe that feeling that they finally have reached that place, maybe they feel completely helpless in that. Maybe they're like, I don't know what to do. This is all new for me. How do I navigate through this? And then often, as in behavioral health, I think across the continuum, there is that sense of they could be in denial. Maybe it's due to symptoms, or maybe it's just due to the fact that they feel like they're in the wrong place, or they've tried this before. So what's the point? So
yeah.
But as they progress, and Travis is going to talk about this middle part, you'll see a different part.
Yep. And so in the middle of treatment, so in a 10-day stay, perhaps by day 5, you're going to start to see some more optimism and hopefulness. As people start to buy into what you're talking about, learning recovery skills, they're going to become more engaged, more stable. They even get to start applying some of those new skills. Maybe when a new fellow client comes in who is triggering them or reminds them of a family member, they can learn new ways to effectively communicate with that person, which can when they do see that family member again. And then at the point of discharge, depending on how long your stay has been and what kind of treatment you've had, but also, and we'll talk about this in a little bit, what your discharge disposition is, that can impact how you're feeling about discharge.
Right. So I think, often when people make it to that point, they've been through the program for a length of time. It's often that they might feel very, very similar to when they first admitted. You can see it in the arc that across the continuum, across the time, that you can reach that point at which you're having ambivalence. You're having more fear than when you originally entered the program, because you've reached that point at which you're now you're now set to move out into the community, and you have to rely on yourself instead of relying on the support of the staff or the support of the program structure or those types of things. So often people are in fear of relapse in behavioral health symptoms, or even relapse in drug and alcohol issues. I mean, it's no secret, I think, that mental health and substance abuse often, are co-occurring issues that a lot of our individuals struggle with. But then there also might be this sense of a return to certain freedoms and all the feelings that go along with that, whether it's excitement, fear, trepidation, those types of things. So I think, the admission continues arcs into discharge. Often a person can feel maybe the same or like at the time they felt it in admission, depending on what was addressed and how it was addressed at the arc of that treatment.
And Pete, this can really pull on the heartstrings of staff who have been working with these people for a few weeks, especially if a person starts to maybe try to manipulate the situation and says, if I'm going to leave, I'm going to hurt myself, or if I'm going to leave, I'm going to be right back here. I'm not ready. It can still be hard if you've seen someone make a lot of great progress, because in crisis work, you're helping someone from a very difficult place. They start to get better, and then they leave, and then you're going to do that over and over again with people. So there is some closure that happens on both sides that can feel a little bit, it can bring some mixed feelings with it.
Mm-hmm. And I think something to pay attention to when it comes to that arc of treatment is how long is this arc? If it's 3 to 5 days, if it's shorter, those feelings of ambivalence or fear, those might be stronger than if the time frame that the arc happened on was longer. So, and I think that's the issue we're trying to address here, is what is that golden spot? What is that right time for treatment to be most effective?
That's right. So an important concept here as we're thinking about this whole treatment approach is that what a system believes about a person in crisis impacts their outcomes. And so the way that we talk about people, if we don't use first person language and we refer to someone as the drug addict or the schizophrenic, that can impact our belief in their ability to get better and in their overall recovery. And we have to be very mindful of that. And if we don't, embrace strengths-based language, or if we don't embrace a belief that people can get better no matter how many times we've seen them, we're doing a disservice to them. And that brings us into a conversation about hope. So we want to talk about, is there research behind hope in the crisis settings, and how do we measure that or infuse that into our systems? So there's two ways to look at hope. The first one is hope as hope, and what that means is literally assessing hope and asking about a person's hopefulness. The second is kind of defining it by what it's not, and that would be reduced acuity or symptoms as hope, such as reduced depression, reduced suicidal thoughts. And so we're going to talk about both of those and some of the work that Telecare has been doing around measuring hope within the crisis residential programs. So Pete, tell us about the Hope Index.
So the Hope Index is a tool that's used mainly at one of the programs in the Central Valley in California. It's an evaluation tool. It measures the hope of an individual in a crisis residential treatment, and it's measured both at admission and discharge. So an individual enters the program, they're asked a series of questions across the scale of based on hope. How strong is your hope? How hopeful do you feel? Rate on a scale of 1 to 10. You give me a number, and then they're measured again halfway through, and then at discharge. And those are weighted against each other. And often, in looking at hope, it varies from person to person, and it varies on a pretty wide scale, given certain maybe individual factors that person has going on with their treatment, to maybe very personal factors that person having going on the treatment.
So we're going to take a look now at some data that y'all have collected at Telecare, and to
Mhm.
get an idea of how length of stay might impact their hopefulness. So we've got the Hope Hearth results here, and the client ID is on the bottom. So the people with the longer lengths of stay have the higher numbers on the bottom. So client 34, 35, those are a length of stay, in the 60s or in the 80s. And then the orange bars are the change in their Hope score from admission to discharge. Now, this is something we don't do a lot in behavioral health crisis services that we should do, which is a simple pre and post test. Ask people a series of a couple of questions, nothing too overwhelming, that you can compare to the end to then show your funders or your community partners to say, look at the impact we had because of our treatment. Now, Pete, the numbers here are, it's kind of a smattering. You can kind of see between 5 and 9 days there's a high level of hope. Some of the longer lengths of stay have some of the highest scores, but then there's some discrepancies, and I'm going to draw our attention to a few of these, and I wonder if you could tell me what you know about these data points right here that had the largest decreases in hope ratings.
Yeah, so these two individuals, you can see one individual was admitted for 15 days. Their length of stay was 15 days. And from the time of admission to discharge, their level of hope based on the Hope Hearth Index dropped by 5 points. And then the other example, you have an individual there for almost 29 days, and upon admission to discharge, their index score dropped 5 points as well. Both of these individuals had some specific things going on, but what was common amongst them was they were unable to secure housing upon discharge, and that really played into a key role in regards to their level of hope from admission to discharge.
So what I'm hearing you say, Pete, is that we need to control for some factors as we continue to research to collect this kind of data, and controlling for stable housing or returning to the housing that they had before might be one of the ways that we could do that.
Yeah, definitely. That part of a person's recovery, both across the continuum, across the areas of stabilization, respite, and recovery, and the final phase, is very important in regards to how hopeful or how much a sense of resiliency that person feels that they're able to start once they leave the program.
Yeah. So the other way we're going to look at hope is reduced symptoms as an indicator of hope. And so there's a few studies that are out there, and many of them are around CAMS, which is a suicide assessment tool, which is also being featured and discussed in the Crisis Residential Conference. So hopefully if you haven't already, you get a chance to catch that session. But one of the studies said that weekly group therapy decreased suicidal thoughts, depression, and hopelessness. So maybe, depending on your length of stay, this could have to do with the therapy or the support groups that you're involved in at the Crisis Residential Program, or it could have to do with your postvention or your aftercare. And the second was that targeted clinical interventions reduce suicidal ideation and long-term mental health distress, and lead to higher satisfaction and treatment retention. So these are two areas that we could put more thought and effort into researching around crisis residential to say, what does treatment as usual look like? We know that there's about 20 or 30 studies that support the efficacy of crisis residential and the outcomes compared to psych inpatient, but we need more information like this in the crisis residential environment to understand what exactly is making it work. So we did our own survey with the Crisis Residential Association that was sent out to providers in September of 2020, and we asked them just a few basic questions about outcomes. We had 43 responses, and here are some of the results. The first said, how do you assess the quality or effectiveness of your crisis program? And I was so happy to see this result. 88% said they use satisfaction surveys at discharge. Now we could take this with crisis residential providers across the country and peer respite providers. with something like a 1-question Likert scale that says, I was highly satisfied with the services I received. And then you rank it on a 4-point or 5-point or 6-point scale. And then we could actually start to get some data nationally with a consistent tool, something as simple as that. I also want to draw your attention to the fact that symptom rating scales were used very infrequently, asking people to rank their depression on a scale of 1 to 10, their anxiety, et cetera. And so there's an opportunity to do that more within the facilities. Time, excuse me, can certainly be a reason why we don't do that. But as we're going to show you in a little bit, the time that the staff within the crisis homes don't get to spend with clients can have a negative effect, to say the least, on client outcomes. So here's the next question we asked. What are the critical components that of your crisis program that make it most effective or most helpful? And the majority of people, the 2/3 or more, said the staff traits, not the education, but the traits like empathy and friendliness, or the ease of access to the service, or the access to strong clinical resources, are what made it really good.
Mm-hmm.
And then I think this might be our last graph, and it's a 2-parter. So we asked people, if there is an ideal length of stay where you see the most success, choose what that is. So you can see there was a wide distribution. The largest response was 6 to 7 days, but that only got about 21%. And so we took this data and we put it into 2 buckets, either less than 7 days or more than 7 days. 62% gave an answer that was more than 7 days. 38% gave an answer that was 7 days or less. This might tell us that effective crisis residential treatment should happen in an 8-day or more window in order to be the most effective. So Pete, I think you have a green egg. Tell me about your green egg, what you like to make in it, and why the timing that you spend on it, matters so much for a good food outcome, we'll call it.
Oh man. So lately I've been making bacon. That was like that is like I don't know if anybody out there really, if you guys like bacon, but when you make your own bacon, oh, it's like God put pork fat out there just for you to brine and smoke. It's fantastic. So, but I think we can all agree that if I was to go using the fast food analogy versus a slow cooker analogy, I think we could all agree that if I was to go pick up something from a local restaurant that makes it a fast food restaurant, am I going to be as satisfied, or am I going to feel as like I got the most out of that meal compared to if I slowly take my time, prepare the meal, cure the meal, and then check in on it on 15, 20-minute, 30-minute, hour time frames, basting and taking my time with it? Which meal is going to be more satisfying, or which meal am I going to feel more that I got the most out of? And I think across the board, what you'd see is most people would say that meal that took you time, that you had to actually spend time manipulating with your, with new spices or basting or those types of things. I think people are going to say that was the meal that satisfies the most.
And I bet if all your green egg friends that cook bacon are doing it at a set number of hours, let's say 10 hours to get it just right, there's not going to be many people that are doing it for 3 hours and getting the same outcomes.
Right.
That you're messing with a good thing, and people just might kind of all agree that you need this amount of time in order to create a quality product at the end.
Yep.
So Pete, I'm jealous of you. You have In-N-Out where you live.
Oh yeah.
I am fortunately. Oh, look at you!
Check it out, man.
Look at you!
Look at that.
So Pete, as a wannabe In-N-Out worker, what's the impact of trying to act like a fast food chain on a provider? What happens?
Well, certainly you really don't get this. You don't get the outcomes that you would get on taking your time with some sort of treatment. Maybe it's not enough time for the medications to take effect. you're looking at a very, very short window to even develop rapport. If we're asking an individual to develop rapport within 3 to 5 days, for most people, that's even difficult even remembering names, the staff and the resident. Or you're talking about the excessive time and administrative burden based on such a short length of stay. Travis is going to talk a little bit about this right now, but you have a very brief window to manage a lot of what needs to be done in order to meet maybe state or county regulations in regards to documentation standards, which creates less time to spend with your residents.
Great. So let's have a little math lesson. For those of you that are burned out from doing schoolwork with your kids at home, I apologize, but hopefully this one comes a little bit easier than whatever version of math your kids' schools are teaching. So let's say we have a 6-bed crisis residential program or a 6-bed peer respite program. And the length of stay on average is 2 weeks or 15 days, so half of a month. We've got 6 hours of paperwork per person when you count intake and discharge and maybe progress notes. And there's about 3 groups per day, facilitated psychoeducational or support or therapy groups, process groups. So the way we're going to do that math is that 6 beds and 15-day length of stay. That means every bed's going to turn over once in a month. We're going to have 12 clients, okay? 12 clients and 6 hours of paperwork per person is 72 hours total, and 12 clients getting 3 groups per day, or excuse me, 6 clients being there for 15 days. So 15 days and 3 groups per day. That means 45 treatment hours per client. That's awesome. It would take, if you were going to group therapy and you only went 1 hour per week, it'd almost take you a year to get that many, and you could get that in 2 weeks. Now let's compare that. If we change the length of stay, we cut it by 2/3 from a 15-day length of stay to a 5-day length of stay. Well, now we're seeing 36 clients instead of 12 in 1 month. We've got 216 hours of paperwork. Imagine that burden if you're a direct support professional or a clinician or a peer support. And we got 15 treatment hours per client. So instead of 45 in a 2-week stay or 15-day stay, we're only getting 15. Now I'm going to cut these numbers up a little bit differently. What this means is that in an average length of stay of 15 days, it's 2.5 hours of paperwork per day per person. If there's an average length of stay of 5 days, it's 7 hours per day because you have the same amount that you have to do in a much shorter time. Now, this would be if you had all your clients together in the facility. So the expectations remain the same, but you have less time to do them. So you have less time to cook, less time to do precaution checks, like a 15 or 30-minute check on people, less time to administer medications, and then group facilitation and activities. What is the first thing that always goes in a schedule, right? If you've got something to do, I find it to be groups. Groups were always the thing in my crisis home that people would give up first in order to take care of something else. Yep. And that's not necessarily wrong. It's just kind of what happened.
And you have less time to make a connection to somebody. That is one of the most important things that you can establish in a crisis is making that connection with somebody. If I only have 5 days to do it and I've got to spend 7.2 hours of my day doing paperwork for that person's 5 days, I have only about 0.8 of an hour to build rapport and let them know that I'm there to help them.
Yes, and Pete, oftentimes that's what clients who have discharged say was the best experience, is they name a specific person, right, or a case manager or a clinician or someone that they worked with and said, this person made the difference for me. They had the time, they took the time. And you're totally right. We missed that bullet point, but rapport building just gets also taken away when we have higher expectations for other things.
Yep.
So Pete, let's talk through these solutions. What do we need in order to get where we want to be with understanding how to be the most helpful?
Hands down, I think there, and Travis and I agree on this, and we hope you guys agree, is that more research needs to be done to look at, what is that sweet spot of treatment time that it takes to make the crisis residential services the most effective they can be. So more research needs to be done on this. Need to look at efficacy and those types of things. Better data collection. across the board. Whether that's in in standardized outcome data for crisis residential programs, or maybe program specific data, but more data and controlling for independent variables across all program types, and then better outcomes. So what
Yeah, so,
Oh, sorry. Go
sorry,
ahead.
Pete. I was going to say, with better outcomes, that means that actually crisis residential providers need to be held to a higher standard.
Yeah.
That just existence is not sufficient, but we've got to kind of prove why this model is important and why it works. And that's what should justify the continuation of it or the development of new programs. And then lastly, we need national standards in crisis residential care. So we need to know from our language of what is this facility, what is that facility, to what can we all agree upon is the definition of success from a provider's perspective, and then also from a person receiving services perspective. So a couple additional resources to keep in mind: the Crisis Residential Best Practices Handbook and the Crisis Residential Research Summary. These were both done as joint efforts between Crisis Residential Association and TBD Solutions. You can find these, I believe, on both the CRA website as well as the TBD Solutions website. And the last question we want to end with is faster better? Is it better in fast food? Is it better in crisis residential services? And is that the measure that we should be taking up when we're talking about the quality of these services? So thank you so much. It has been a pleasure to spend time with you, and we'll be making some time here now at the end for Q&A. But on behalf of Pete and myself, it's been a pleasure, and we hope you enjoy the rest of the conference.
Great. Thanks, you guys.
I think we're waiting for Chris and Travis to join here.
Can you see me, Pete?
Yeah, I got you. There you are. Hey,
all right, cool. Hey, we're going to try and field some questions. I know that we're pushing up against the next session, but thanks for hanging out with us. And as soon as I see Chris get on board.
Yeah.
And Chris is asking about the outcode too, and I'm going to try and look that up here while we're talking. But I'm going to get to one of the questions that came in, which was, how can you most effectively run treatment groups with individuals who may be at very different stages in their crisis residential stay? And I think this is a great question. It's really important. And technically, the longer length of stay you have in your program, the more people are going to be at different phases, so to speak. Like if you only have a 3-day length of stay, then people are either at 1, 2, or 3. If you have a 14-day length of stay, it could be a lot more. But then again, if you put them into the buckets that we told you, of acute stabilization and then respite, then they might be more comparable. I would say one of the inspiring things that I've seen with crisis residential clients or people that have been served in these facilities is sometimes they follow a path where they start off as a person who needs to learn or is learning a lot and absorbing things, to someone who helps their peers through the process and said, hey, I came in here a week or two ago, I felt just like you did. And just that level of empathy can be more powerful than anything that the staff do.
Yeah, I agree. The buddy system, or if you have instituted at your program where newer members are oriented or toured by longer term residents, I mean, I think that really starts a person's stay off in an accelerated phase of hope, if you pardon the analogy. Is this person gets to see firsthand, like, this guy or girl, whoever, was just like me when they got here, and look at them now, look at how well they're doing. They also get a fresh perspective from somebody who's been through the services, not one of the staff who, to be honest, they probably are a little bit more weary of. They probably, they want to see, talk to that person that's been in their shoes. And I think that is a fantastic way. So the buddy system, or what you even talked about too, Travis, that phasing system, I see benefit to it. But I tend to see a greater benefit in commingling people with shorter time and longer time, because it's often in those group settings you get that person that's been there longer that can reach that person who's been there shorter more than maybe a staff at times. So that's my preference.
Yeah, another thing that I'm noticing in that's coming up in some of the group discussions we've had, like the virtual roundtable today and the chat and chew yesterday, is the ways that crisis providers or crisis homes are getting the people that they serve involved in the day-to-day operations of the facility.
Yeah.
And I don't mean like do chores, like you're going to do the laundry so I can sit down here, but I'm almost thinking the movie that I always come back to is Patch Adams. And in Patch Adams, by the way, is a real person, and he's amazing, and you should check out his TED Talk and a couple of his other talks. But in the Patch Adams movie, when he starts this house for healing, and he has all these doctors in there that are delivering free care, what he says to people, whether they come in with depression or a broken arm, or if they have diabetes or something, is everybody has something wrong or something going on, but that doesn't mean that everyone can't be helpful in some way. And I think that mentality is great. Like some crisis programs that are attending our conference, they've got gardens, and the person served are invited to harvest the crops, if you will, or the tomatoes that are coming out of the garden, to get ready for dinner together, to prepare the meal. Unfortunately, the communities that I worked in doing crisis residential, they were very very risk aversive. All the knife drawers needed to be locked because there was a person in the facility who was suicidal. You can contrast that with what's going on at the Harris Center in Houston, Texas, where they host a Thanksgiving meal for their alumni, and they invite people who have been through the program to come back for groups. Mendy Snodgrass, who has since retired, presented at our first conference, and she and her colleague, I think her name is Diane Jackson, just presented on all of the wonderful things that they do to bring life into the facility and into the program, instead of treating people like they're primarily their diagnosis or their symptoms and saying, well, we can't have you doing anything risky.
Yeah, I'm so glad you bring up the alumni groups. This is an aspect of crisis residential services that I think a lot of programs should institute. I know it's really familiar in the substance abuse model that if you go through treatment, you can attend groups and do the alumni groups and that type of thing. But I think that speaks volumes. You get imagine the wealth of data that you could collect on efficacy if you held an alumni group where you saw a person come in, you could track how well they're doing after they leave the program. You could then correlate that to their length of stay, and you could make an easier connection between the two. But now, most discharge plans, we discharge and then we make a connection via, I don't know, a phone call, or we look up how many interactions you've had within the EHR, the computerized system, where what you're missing is that person's ability to share their experiences, not only with somebody who's new, but with the program, so the program can learn how to be a better program from first-hand accounts rather than kind of guesswork out of data.
There's another question that came in that said, so is hope about length of stay or feeling safe in the discharge plan, which may take more days to develop due to systems? Beth Nelson brought this up from Productive Alternatives in Minnesota. Beth, so glad you're here again. That is, I think, one of the hardest things to do as a crisis residential provider, if you only operate your facility in the continuum in your community, is to rely on others and what they're doing after they leave your facility. So if you don't operate outpatient services or psychiatry, then you can't control if they can actually get that appointment within 30 days to line up with when their refill expires. And that can be really, it can make you feel helpless as a provider to do all this work, but then not have things ready. And so I think these need to be collaborative conversations that happen with the payer, with the continuing stay review person. I had Elizabeth from Beacon, who was a joy in the virtual session that we had, and she was talking candidly and openly about the importance of long-term stabilization as the result of a crisis intervention, instead of just getting people in and out as quickly as possible. I think that's a progressive mindset that more health plans have to adapt.
Yeah, and I think that, and unfortunately, we talked about this, is that the data really doesn't connect hope and length of stay. It varies across the board, and it's really specific to a person's, to a lot of variables that are going along with a person's stay. So can you make a direct correlation between the two? At this point, I think it's kind of up in the air whether you can certainly do that. But I really think that it's difficult to overlook a length of stay as it relates to how a person is feeling, or the resiliency that they have at the time of discharge. You could get that person that finds that sweet spot, and they leave feeling the most hopeful that they can feel, and they are a success. You could get that person who they just stayed just a little bit too long, and for whatever reason the plans fell through, or they thought they weren't ready to go, and so they held off on their discharge, and it creates a loss of resiliency. So it's hard to say, and it's but certainly that those short models, that 3 to 5 days, I think those providers, I take my hat off to those providers who try to do crisis residential services in 3 to 5 days, because that is some tough work.
It's a tall order.
Yeah, it's a tall order. I agree.
Just a couple more things. If you haven't been watching the chat, the out code for this session is EN. And I wanted to also say, to touch on our recommendations and like really tangibly getting this to the next step. There are some common threads that are coming through our sessions here this week with the conference, and partnerships with universities is one of them, and Rania and Dan presented on that yesterday. But the need for more research is another one. David Jobs and his colleagues through, I believe, the Catholic University were presenting yesterday on CAMS, which we referenced in our presentation. What this looks like practically when we say we need more research, that's not a phrase that we just need to put on the shelf and say, okay. Like, we have to engage conversations with our local universities that have research departments and find out what those partnerships could look like. The American Association of Suicidology has great relationships with researchers and research institutions. That might be an organization for us to partner with and say, how can we offer up our facility, our program, as a place to be researched. Facilities like Dan Mesha, and I know a lot of his colleagues are here from Community Research Foundation, they've had a number of research articles written. We have no research since 2013 on crisis residential programs, even though we have about 35 articles between the 70s and that year. So think about this. If you have good relationships and are bringing in social workers and psychology interns and things like that from these schools, think about what research partnerships could look like too, because we need data. We need these things. We know that the service works, but we can't articulate why it works from an evidence perspective. So that's our kind of our call to action to all of you is
I'm sorry, Trev. I was just going to piggyback on what you're saying, which is, it's often that you see the data, you look at the data, and the math doesn't lie. The math is always going to tell you, what's been most effective. And, I don't know if you guys had an opportunity to check out Johnny Gaspar's talk earlier today. There's an opportunity where they are effectively using data to locate specific points of efficacy within a continuum, and you can see the success that they're having when they use data and then they attach it to areas where they see gaps, or areas where they see success. And I was just really impressed with that talk, and so it's really the call for more people to start collecting these things and getting them in some sort of central database for other programs to look at or start talks about. I mean, this is where crisis res really could soar.
Yep. And just as the last plug, CRA can be a place to do that. So if you want to get involved, if you want to start a research committee within CRA, that would be welcome. We would love that.
Fantastic plug. I love that. I'm going to vote yes. CRA is the place to start. There's no other place to do it.
Don't leave that as a hanging chad. Fulfill that chad completely.
Exactly. You're not going to do that at some corner store. No. You're going to do that at CRA.
All right. We got 5 minutes before our TED Talks, and we have 3 TED Talks today, which we're very excited about. So go get a drink, take a bio break, and we'll see you soon.
Thanks, guys.